Department, King Faisal Specialist Hospital and Research Center in Riyadh. I would like to thank all of you for attending with us tonight and joining our webinar tonight. Also, I would like to thank Takeda for their participation in this webinar. We are going to have tonight two speakers, actually, prominent speakers, and they are going to talk about two sessions, one about multiple myeloma and the second one about Hodgkin's lymphoma. In fact, our first speaker is Professor Shaji Kumar. He is a consultant hematologist in Division of Hematology, and Mark and Judy Mullins, Professor of Hematological Malignancies, Mayo Clinic, Rochester in Minnesota. He served as Medical Director, Mayo Clinic Center, Cancer Center, Clinical Research Office, and Mayo Clinic. He underwent his undergraduate in India and graduated, and also did his fellowship in India. Then he moved to the United States, where he joined Mayo Clinic. He is going to tell us tonight about how I treat multiple myeloma in relapsed post-autologous stem cell transplantation. Please, Professor Kumar.
Thank you so much, Dr. Al-Sharif. I think I can go ahead and... Good evening, everyone. I know it's late at night for all of you. What I would like to try and do over the next 20 minutes is to talk about the current landscape of management strategy for patients who relapse after autologous stem cell transplantation. These are my disclosures. As you all know, the treatment paradigm of myeloma has evolved considerably over the past decade. However, some of the fundamental approaches have remained the same. For patients who are eligible for an autologous stem cell transplant, once they are diagnosed and undergo risk stratification, will get induction therapy with one of the 2, 3, or 4 drug regimens, followed by consolidation, which is typically a single autologous stem cell transplantation, which is then followed by maintenance therapy given for variable periods of time. In contrast, patients who are transplant eligible often undergo induction therapy that is then continued for a prolonged period of time. So unfortunately, the majority of the patients with myeloma will eventually relapse. And at that time, we have to think about what our treatment strategies would be that will allow these patients to have the best outcome. Now, as you all know, with the current standard approach of using a single autologous stem cell transplant after a VRD induction has been studied by the French in the IFM 2009 trial, where they were able to show that a single autologous stem cell transplant was able to improve the progression-free survival compared to RVD alone, even though the overall survival appears to be quite comparable between the two groups. We also know that the stem cell transplantation allows for deeper response with higher rates of minimal residual disease negativity compared to the single transplant. What we have learned over time is that patients who relapse very soon after an autologous stem cell transplant have a very different biology and outcome compared to patients who have prolonged response after an autologous stem cell transplant. And this has been studied in multiple different studies. This is one study that was done at Mayo Clinic, where you can see that the overall survival of patients who relapse within 12 months of their autologous stem cell transplant is rather poor, with a median survival of only about a year. And as you can see on the right-hand side, again, the longer the time that you take to relapse after an autologous stem cell transplant, the longer you survive after the time of relapse. So if you take 2 years, your survival from there is roughly about 18 months. And if you relapse after 3 years, then it's about 2.5 years or so. So we recently looked at the data from the CIBMTR registry, and again, we see the same thing in patients who relapsed beyond 2 years compared to the patients who relapsed within 2 years. you can clearly see that their overall survival after relapse is very different. And even though the survival of some of these patients have improved in the recent years, it still remains rather suboptimal with the current treatment approaches. So what are the risk factors for someone to relapse early? Obviously, the sensitivity to the chemotherapy prior to autologous stem cell transplant, the ISS stage 3 diagnosis is an important factor. Whether the patients get maintenance or no maintenance is important. And obviously, with the introduction of novel agents, this risk has gone down, but still it remains quite high. So the first question that comes up when you have someone who has gone through a transplant and is starting to relapse is whether we need to start therapy right away or whether we can wait. In patients who have clinical progression or CRAP features, there's clearly those patients need to be started on treatment. There isn't any question about it. The patients, in contrast, who have a standard risk disease with a very slow trend in their M spike going up over time, those patients can sometimes be watched for a period of time before we start them on therapy. However, patients with high-risk disease or patients who originally presented with renal or neurological complications or patients with rapid doubling of M spike, those patients should all be started on therapy as soon as you see a biochemical progression, and we do not want to wait for end organ damage. There are some general principles that you can use. One of them we already talked about the duration of initial response. The other thing that we have known over time is that patients should be started on at least a triplet combination with at least one drug from a non-refractory class of drug, and preferably both drugs being from non-refractory classes, or at least a new drug from the same class. You want to take into account the performance status, the age, and the comorbidities of these patients. You also want to take into account what kind of toxicities they have had before and what is left behind. And the game plan would be to treat these patients to maximum response and then maintain them on at least one of the drugs till disease progression. So how do we select treatment? There are multiple different factors that needs to be taken into account, including the type of prior drug exposure, the risk status, the age, the frailty, comorbidities, the toxicity with prior drugs, whether these patients can undergo another autologous stem cell transplant, and obviously the patient preferences and logistics of drug administration. So let's take a look at each of these characteristics and see how we make our decision based on that. So the first question is, how would you treat a patient who is not refractory to bortezomib? Now, there are several phase 3 trials that has given us information about how to treat patients who are not refractory to bortezomib. This is the Endeavor trial that randomized patients to getting carfilzomib dexamethasone versus bortezomib dexamethasone, showing that carfilzomib given at a higher dose can actually improve the PFS and improve the overall survival compared to standard doses of bortezomib and dexamethasone. Now, the Panorama trial looked at adding a histone deacetylase inhibitor, which is panobinostat, to bortezomib dexamethasone, and was able to show that there was about a 4-month improvement in PFS with the addition of this new class of drug. We have the Castor trial, which looked at the addition of daratumumab, which is the monoclonal antibody that is targeting CD38 on the myeloma cells. And you can see that the addition of daratumumab clearly improved the progression-free survival for these patients. And finally, we have elotuzumab, which is another monoclonal antibody that is targeted towards SLAMF7 that is present on myeloma cells. And again, here you can see that addition of elotuzumab to bortezomib dexamethasone improves the progression-free survival with some trend towards an improved overall survival as well. What if the patients, in someone who is refractory to lenalidomide, you obviously want to start something different. So here's a trial that looked at addition of a pomalidomide, which is another immunomodulatory drug, to bortezomib dexamethasone. And you can see here that the patients who got the 3-drug combination had a better progression-free survival compared to just bortezomib and dexamethasone. Now, what about patients who are not refractory to lenalidomide? Now, the current practice is often to continue patients on lenalidomide maintenance until progression. That means the majority of the patients are going to be refractory to lenalidomide but sensitive to bortezomib. So the trials that we just talked about probably applies to them more. However, there are going to be patients who did not get post-transplant maintenance therapy and who may not be refractory to lenalidomide. For these patients, again, there are some phase 3 trials that are quite informative. The ASPIRE trial looked at the combination of carfilzomib with lenalidomide dexamethasone, improved progression-free survival, improved overall survival with the triplet compared to lenalidomide dexamethasone. Another trial looked at ixazomib. Now, ixazomib is an oral proteasome inhibitor, the only oral proteasome inhibitor that we currently have available. And it also allows us to create an all-oral combination that is particularly relevant in today's setting with the pandemic, where we don't want patients to come back to the clinic very often to get injections and so forth. And here you can see that the ixazomib significantly improved the progression-free survival compared to lenalidomide and dexamethasone doublet. Now, the ilotuzumab has also been combined with lenalidomide dexamethasone. This is the ELOQUENT trial. You can see that there's an improved PFS and also a trend towards improved overall survival improved overall survival with ilotuzumab lendex compared to lendex. The daratumumab has been combined in the POLLUX trial, where the monoclonal antibody was combined with lenalidomide dexamethasone, compared with lenalidomide dexamethasone, improved the progression-free survival. We don't have the data for the overall survival for this trial yet, but certainly a significant improvement in the PFS. Now, what if the patients are not refractory to lenalidomide or bortezomib? For those patients, you have a wide variety of choices. You can always use the combinations like VRD that you may have used in the beginning. You can repeat any of the injection therapies. VCD could be another combination. So the choices remain very open for patients who are sensitive to both these drugs. Now, what about patients who are refractory to both lenalidomide and bortezomib? Now, these are the patients who can be more challenging because now we have to look at a new class of drug. Now, daratumumab as a single agent has been used in patients who are refractory to both lenalidomide and bortezomib. And here you can see that even in those heavily pretreated patients, almost a third of the patients actually responded to the daratumumab as a single agent. Now, similarly, the carfilzomib has been used in combination with pomalidomide and dexamethasone. So this is a trial. Obviously, now if someone was refractory to both bortezomib and lenalidomide, this combination will allow them to get two drugs that they have never seen before, even though they belong to the same class of drug. And you can see here that it's a reasonable PFS and a reasonable overall survival for a heavily pretreated group of patients. Now, daratumumab has been studied in combination with pomalidomide. This is a single-arm trial where they found that almost 71% of these patients actually respond to the triplet regimen. And again, with some of these patients getting a deep response as well. Now, there's a phase 3 trial that has been done with daratumumab pomdex versus pomdex, which is also positive, but we don't have all the results of that trial available yet. Now, ilotuzumab has been combined with pomalidomide dexamethasone in a randomized phase 3 trial. Here again, you can see that there is a significant improvement in the PFS with ilotuzumab, lendex compared to pomdex compared to pomdex, and there is a trend towards an improved overall survival as well. Now, the other strategy has been to try and combine the proteasome inhibitors with the monoclonal antibodies. So the CANTOR trial looked at combining carfilzomib with daratumumab and dexamethasone. So it looked at a PI plus IMiD triplet versus a PI dexamethasone. This trial showed that the addition of daratumumab to carfilzomib significantly improved the overall response rate as well as the depth of response, and also improved the depth of the rate of minimal residual disease negativity. And this actually did translate to an improved progression-free survival for the carfilzomib dexamethasone daratumumab versus carfilzomib dexamethasone, and again a median PFS that has not reached compared to 16 months. Now, a similar trial has been done using isatuximab, which is another CD38 targeting monoclonal antibody, and very similar design, randomized to getting isatuximab with carfilzomib dexamethasone versus carfilzomib dexamethasone. And you can see that very similar results: improved depth of response, improved MRD negativity rate, which then translated to a better progression-free survival with isatuximab carfilzomib dex, median progression-free survival not reached versus 19 months with carfilzomib and dexamethasone. Now, the problem really arises when the patients become refractory to even an IMiD's proteasome inhibitors and daratumumab. Now, obviously, this is not very common in somebody who is just relapsing from stem cell transplant, because many of these patients may not have been exposed to all these different drugs. So, but this is in the future when we start using the PI imidaratumumab combinations in the pre-transplant setting and putting them on potentially a monoclonal antibody plus lenalidomide maintenance. These can definitely become a challenge. And obviously, the introduction of new therapies can help us overcome those issues. Now, how do we select the treatment, right? So we talked about the prior drug exposure and the refractory status. There are several other characteristics that are important as well. One is the risk status. Now, the risk stratification in the relapsed disease is equally important as it is in the newly diagnosed patients. We already talked about the duration of initial response, patients with primary refractory disease, patients who get new abnormalities like 1q amplification and 17p deletion, patients with RISS stage 3, poor performance status, extramedullary disease, or circulating plasma cells, even if they don't meet the criteria for plasma cell leukemia, are all considered to be high-risk features. So what should we do for the high-risk patients? I think just like what we talked about, we want to do triplets. We want to use drug classes that the patients have not been exposed to, and we want to treat them to maximum response and preferably get them to an MRD negative state, because those are the patients who appear to do best with a high-risk cytogenetics. And there are certain drug classes that may be more relevant. We know that the proteasome inhibitors are particularly important for patients with high-risk translocations and 17p deletion. Now, what about other chemotherapy agents? These drugs can also be quite effective, especially in patients with extramedullary disease and plasma cell leukemia. We often use combinations like the VDT-PACE combination. And this is, again, a limited experience from our own center. And you can see that even in patients with highly refractory disease, using a combination like VDT-PACE, you can get an overall survival, and again, of about 8 months. PFS is about 3.1 months. But again, we think about the VDT-PACE as a way to control the disease, as a bridge to some other therapy, like a transplant or getting them to a CAR T-cell therapy and so forth. Now, the next thing to think about is the age, the frailty, and the comorbidities. Obviously, some of these patients might have become older. Obviously, they would have become older since their stem cell transplant, and they may not be in the same good condition that they were when they went to an autologous stem cell transplant. So patients who are older or who are frail, we can still use all these drugs that we talked about, but we want to try and see if we can use them at a lower dose, depending upon what kind of risk factors that they have for frailty and comorbidities. What about the toxicity with prior drugs? This is very important as well. What if patients have peripheral neuropathy with prior use of bortezomib, right? So we don't want to use bortezomib again. We could consider using ixazomib or carfilzomib. What if patient has had cardiac failure with prior therapies? Then we want to try and avoid carfilzomib. If they have renal insufficiency, we want to try and dose adjust the lenalidomide or use a drug that doesn't require dose modifications. If they have had severe skin reaction with IMiDs, like Stevens-Johnson syndrome, for example, you certainly don't want to try and use the IMiDs again. Now, what about the transplant eligibility? Now, this is also important because patients who have not had a prior transplant, obviously we can use that again. But even in people who have had a prior transplant, a salvage autologous stem cell transplant could be of value. This is a phase 3 trial that was done in UK where they randomized patients to getting traditional chemotherapy versus an autologous stem cell transplant. And you can see that the PFS was significantly better, even though we have really not seen a lot of overall survival difference yet with the limited follow-up. Now, one of the things to keep in mind is that patients who have had a prolonged response to their initial stem cell transplant are the ones we want to consider for taking to a second autologous stem cell transplant. A general rule of thumb has been that if your initial response was less than 18 months without maintenance or less than 3 years with maintenance, you don't want to take them to a salvage autologous stem cell transplant. Finally, you want to take into account the patient preferences, whether they want oral therapies, are they able to come back to the clinic often to get IV therapies? And again, we want to decrease the toxicity for these regimens and preferably decrease the frequency with which we want those patients to come back. So one of the possible approaches, again, if you are not refractory to lenalidomide, we want to use a PI plus IMiD plus monoclonal antibody or an IMiD plus PI combination. If they are not refractory to bortezomib, we want to use a bortezomib or a PI-based combination, either with a monoclonal antibody, and in the subsequent cycles, you can kind of change your approach, coming in with a drug that they have not previously been exposed to or not refractory to anymore. So obviously, the post-transplant relapse is the paradigm is changing with all these new therapies and the increasing use of triplets. Obviously, the current clinical trials are looking to see if we can even use some of the immunotherapies like CAR T cells and BiTEs in these early relapse patients as well. But the key thing is to remember how we want to use these drugs in sequence to try and get the best outcome for these patients with myeloma. With that, and I will stop, and we'll be having questions later on. Thank you.
Thank you very much, Professor Kumar. I think for the questions, we shall leave it after the second talk, and we shall have enough time to ask questions later on. Our second speaker going to be Dr. Moussab Damlaj. He is a consultant, adult hematology and hematopoietic stem cell transplantation, Department of Oncology, Division of Stem Cell Transplantation at King Abdulaziz Medical City in Riyadh. He was Doctor of Medicine at Mayo University in Canada, then moved to Mayo Clinic in Minnesota for fellowship and blood and marrow transplantation program. He certified in internal medicine and hematology in Canada as well as in America, and his clinical interest actually in lymphoid malignancies and bone marrow transplantation. Dr. Moussab going to talk about the role of Brentuximab Vedotin treatment of high-risk Hodgkin's lymphoma post-autologous stem cell transplantation. Please, Dr. Moussab.
Thank you very much, Dr. Fahad, for your kind invitation, and the organizers for asking me to speak with you this evening. I was asked to talk to you about the role of Brentuximab Vedotin in specifically the high-risk Hodgkin lymphoma patients post-autologous transplant. So I'm going to talk about some medications in an off-label use setting. So I just have this disclaimer slide for that purpose. So as you know, Hodgkin's lymphoma is a common malignancy in Saudi Arabia, and it certainly tops the 10 most common malignancies year by year. It varies somewhere between being the 7th most common to the 9th most common malignancy. And about half of the patients present to us in an advanced stage. So the likelihood of them being primary refractory in nature or them having primary treatment failure becomes more common. It is a highly curable malignancy nonetheless, and survivors are typically followed long-term by their healthcare provider. Now, the dilemma that we all have in the treatment of Hodgkin's lymphoma, I summarize it in this slide. So when we're talking about early stage disease, the dilemma really is, should we use chemotherapy alone or should we use combined modality therapy? And even though there have been a lot of investigations and a lot of research that has been done in this area, it's still an unclear or an area of, or remains a point of discussion frequently, particularly during a tumor board. The second scenario is in the setting of advanced stage disease. The issue is which is the preferred frontline regimen? Is it ABVD? Is it escalated BIACOP? Or is it the newly approved combination AVD in conjunction with Brentuximab Vedotin? So I'll start off with a case presentation. This is a real case that we had at our center. So he's a 23-year-old male who was diagnosed with classical Hodgkin's lymphoma in late 2015. He was stage 4B disease at the time of diagnosis. So we started him with ABVD, and he was actually PET2 negative at the interim, at the interim stage. He was positive with a Duvel score of 4. So we had a discussion at our own local tumor board, and we upgraded him to escalated via COP, and he received an additional 4 cycles of that. So we did an end of treatment PET scan, or what is known as also PET-3, which showed that this patient is now in complete metabolic response. And we were happy with this outcome. However, a few months later, we did a surveillance scan which showed recurrent cervical adenopathy as well as supraclavicular adenopathy, which was later on confirmed to be relapse disease by histopathology. So the question becomes how to optimally salvage this gentleman who initially proved to be high risk in nature given the positivity at the interim stage and given the fact that he had evidence of recurrent disease in spite of the escalation at the interim level. So we do have a number of salvage options that have been used over the years, and this table is not inclusive, but it has some of the most commonly used regimens such as ICE, DHAP, GDP, and the optimal regimen is really not clear. However, each center has a particular preference given their own experience and preferences. But I think there are 2 important points to take from this slide. The first one is that generally speaking, we do see good response rates with most regimens. So that's why we do think of them as being equivalent, with an overall response rate somewhere being in the high 70s to 80s. And that being said, the complete response with combinational chemotherapy nonetheless seems to be low. And that's usually somewhere in the 20s or 30s at best. So that's the first message. The second message is the patient status prior to transplant is extremely important to predict their outcome. So particularly if they were in a complete metabolic response prior to transplant, we do expect their prognosis to be significantly better. And this has been shown by a number of groups. And this was, in fact, our own experience when, even though we had a small number of Hodgkin's lymphoma patients, when we looked at those that were in complete metabolic response, they did significantly better compared to those that had evidence of residual disease prior to transplant. Now, nonetheless, their overall survival was the same, and a lot of that says to the availability of successive treatments that we have for these patients. Now, over the last few years, we started to see some literature combining Brentuximab Vedotin with the combinational chemotherapy. Now, in diffuse large B-cell lymphoma, for example, the use of Rituximab with a combinational backbone is quite common. So once we started having access to Brentuximab, more and more people were interested in combining it with conventional chemotherapies. And not surprisingly, although we were pleased to see such results, the response rates improved, but more interestingly, the CR rate by PET scan has actually improved. So before, when we used to see the CR rates of being in the 20% range, now we're seeing numbers in the 70s and sometimes higher than that. And a number of regimens were used with BV. Most of them demonstrated feasibility, different side effect profile depending on the backbone, but nonetheless, it was feasible with overall results being quite promising. Now, not only a chemotherapy backbone, but also a checkpoint inhibitor backbone. And in this particular phase 2 study, you see that nivolumab was combined with Brentuximab. And again, we see responses that are good, as well as complete responses by PET scan to be quite promising. Now, at our own center, we, over the last 4 years or so, we started to use Igiv as our preferred salvage regimen in these patients. As you know, the salvage regimens for Hodgkin's generally are either gemcitabine-based or platinum-based. And the history behind Igiv at our center, in fact, dates back to about 6 years ago, where we had a multiply refractory patient that has not responded to typical salvage regimens, ESHAP, mini-beam. And we decided to use a non-cross-reactive chemotherapy protocol. And in this, after some debate, we have chosen Igiv, which is essentially ifosfamide, gemcitabine, venerelbine, and prednisone, which is a regimen that's usually used in Europe, not so much in North America. And we were quite happy with the result of that regimen in that first patient. So we started to use it more and more often in combination with Brentuximab. And we have actually reported on this in a relatively small number of patients, but nonetheless, we were quite happy with the results. We had a total of nearly 30 patients, and we in fact used it. We started using it not as a first salvage. We started to use it what is called here subsequent, so second or third salvage regimen. And then when we got used to it and we were quite happy with the results, we started to use it as a first salvage regimen. And globally speaking, we saw a complete metabolic rate of 71%, regardless of the sequence of use. Although the CMR rate was much higher when it was used as a first regimen. Nonetheless, only one patient was in stable disease, but everyone else responded. The stem cell collection was quite excellent. As you see, the median CD34 that was collected was 13.6 million, with a range that's very respectable. And generally, we started to use this regimen as our preferred regimen. You see that for the entire cohort in the top panel, let me just bring the pointer. You see in the top panel, you see the overall survival and progression-free survival for the entire cohort. But when we stratify them to those that really received it as a first salvage compared to subsequent salvage, you see that it's a very promising regimen. Okay. Now, so going back to our gentleman who was primary refractory in nature, so we had actually given him Brentuximab Vedotin in combination with ESHAP, and he received a total of 2 cycles. We could not put him in complete metabolic response. He still had evidence of residual disease. He went ahead with transplant. However, we did give him a boost area to the area of residual disease early post-transplant. And then we went ahead with BV consolidation post-transplant. In this particular case, he received 2 cycles pre and 8 cycles post. We stopped early because of grade 2 neuropathy that was bothersome to the patient, and he did not want to continue anymore. Now, this is the famous Echelon trial, Athera trial, which led to the approval of Brentuximab Vedotin as consolidation treatment post-transplant, specifically for high-risk patients. And high-risk were defined here as such, so patients that have primary refractory disease, patients that have relapsed within 12 months, and those that have evidence of extranodal disease. They received their salvage therapy, and the salvage was followed by autologous transplant, and then Brentuximab Vedotin consolidation or placebo. And this, in fact, is the 5-year PFS update for this trial, which was published in 2018. And you see that even though the results were mature, they were still unchanged, showing a clear benefit of consolidative BV over placebo. And another point that I wanted to highlight here is you see, given the high-risk nature of these patients, the majority of events do happen in the first year. So if you see at 1 year post-transplant, most of the patients, so about 50% of patients have relapsed in the placebo arm, compared to about 75 or so in the Brentuximab. And the distance between the curves is maintained, even though the follow-up has matured to 5 years. So what have we learned so far? So I think I summarized it in 3 points. The first one is that incorporation of BV pre-transplant as part of a combination regimen results in deeper responses. The second point is that metabolic response pre-transplant predicts outcome. So patients that have a negative PET scan prior to transplant do have a substantially better outcome. And then the last point is consolidative BV post-transplant decreases the relapse rates quite significantly. So I think the logical question was whether using what I like to call a sandwich BV approach, meaning that you give Brentuximab pre-transplant in order to deepen their response, and then you follow this by consolidation post-transplant. And this is actually what we did in this group of 20 patients that were treated at our center. You see their baseline characteristics. Many of them were refractory. Some of them received about 1/3 of them received more than one line of salvage. You see that we used Igiv as the most common salvage, but we used ESHAP and we used bendamustine. The obvious advantage of bendamustine is that it's a convenient regimen given as an outpatient basis. There is a concern with stem cell collection, although that it still seems to be feasible as long as not too many bendamustine cycles are given. ESHAP, one thing I did not mention before, Igiv, one thing I did not mention before is that we, as we started to become more comfortable with it, we are actually giving it as an outpatient basis with special care, obviously, to the ifosfamide with hydration to avoid any bladder toxicity. In this particular group of patients, CMR was actually noted to be achieved in 70% of them, and post-transplant, 80% of them were in CMR. They were followed for a median of 2 years approximately. And again, stem cell collection was not an issue, engraftment was not an issue. We did have, however, one patient that died from organ toxicity, which was ARDS, early post-transplant, and there was no evidence of an infective process identified in that individual. You see that these patients all received a BV consolidation, so they received it pre and post. When they received it post, these were the indications. 14 of them, or 70%, were for short remissions, including obviously primary refractory disease. And then the remaining 30% were for extranodal relapse. The median doses of BV that were given was 15. We did have to stop early for some patients due to side effects. Although about half of them experienced some form of side effect, 30% required some form of dose reduction, but we're still managed to continue the planned course. Again, the PFS and overall survival was excellent, in over 80%, PFS with an overall survival of over 90%. So I think we were quite happy with this outcome. So I think there remains to be some unresolved questions. The first question is consolidation in patients that are in CMR pre-transplant. So I showed you before that patients that are in complete metabolic response pre-transplant do have an excellent outcome. Some of them relapse. However, does consolidation in these patients with deeper responses pre-transplant, is it mandatory? So that's the first question. And there was an attempt at this, in fact, from the original Athera trial, where the patients were in CMR, was part of, or PET scan status prior to transplant was in fact one of the subgroups that were looked at, and there was no clear signal from that regard. So I think this question remains to be resolved. The second question is, can the duration of consolidation be shortened? For two reasons. The first reason is that patients many times, the course of the consolidation can be tiring, experience side effects, as well as the financial implications. And again, this is another unresolved question, although there's some limited literature here and there, and this is one of them where it shows the feasibility of this approach, although you do observe some higher relapses than you would have otherwise. But nonetheless, I think it raises the questions, particularly in settings where patients may not have access to a full course of Brentuximab. So going back to our gentleman, we're close to wrapping up. So he underwent a transplant and he had a stem cell boost as well as consolidative BV. However, he did experience relapse later on in his liver, which was later confirmed. He was started on checkpoint inhibitor nivolumab, and later on underwent a Riks allo transplant in a partial response after receiving nivolumab. So some additional questions with checkpoint inhibition, their safety peri-transplant. So when should we stop them pre-transplant? How quickly should we taper immunosuppression post-allogeneic transplant? And can we start them post-transplant? in patients that relapse after an allogeneic transplant. Some literature with this. This is already now a couple of years old. These are in patients that received checkpoint inhibition pre-transplant, and you see a small number of patients, but nonetheless either a febrile syndrome that is culture negative or acute or chronic GVHD. So this is not definitive, but it did give us some clues. PD-1 blockade post-transplant also was shown to have a signal towards increased risk for GVHD, both acute and chronic. And I think this next study is where it's most interesting, that the risk of GVHD seems to correlate with the time onset between allotransplant and nivolumab exposure. So the closer you are from the transplant, the higher and then where you are exposed to checkpoint inhibition, then the higher the risk for GVHD. So typically what we try to do is stop checkpoint inhibition at least 4 weeks, and ideally longer than that if possible, prior to transplant, and not initiate it post-transplant if feasible within the first 100 days, unless the patient is in florid relapse. An additional point also is that when we initiate checkpoint inhibition, we typically start with a low dose, so that we don't start. So in the case of nivolumab, for example, we start not with the classic 3 milligram per kilo or 240 milligram every 2 weeks, but we usually start with half of that dose, and then we assess response and we try to use the lowest effective dose. So in conclusion, I showed you some literature and our own experience with management of high-risk Hodgkin's lymphoma, and I shown you that the combination of Brentuximab with salvage chemotherapy can result in high response rates with our own Igiv experience, but also with other combinational regimens. BV salvage followed by transplant, I think it can further improve outcomes. There's limited data on this, but I think this is an area that's worth further exploration. And there remains to be much work in classical Hodgkin's lymphoma to further refine how we best treat these patients, both to maximize efficacy and minimize toxicity, both treatment-related and financial. And I think this is all I have, and I thank you for your attention and happy to take any questions.
Thank you. Thank you very much, Dr. Moussab. It was a very elegant talk. While we are waiting for questions, I would like to start the first questions to Professor Kumar. Please, Professor Kumar, when our patients actually with relapsed refractory multiple myeloma, they underwent this salvage treatment and then they achieved response or good response, what are your criteria to take those patients for either auto or allogeneic stem cell transplantation?
Sure. No, I think that's an important question. So patients who have had an autologous stem cell transplant and relapse after that, for a second autologous stem cell transplant, our criteria typically would be that they should have had at least 18 months of response from the first transplant if they were not on maintenance therapy, or at least 36 months or 3 years of remission if they were on maintenance to proceed with an autologous second salvage auto transplant. There are, I mean, it's a relatively, soft line. There are people who might use it 12 and 24 months instead of the 18 and 36. We have been using more of the 18 and 36 since there are so many other therapies that have become available since, since this early analysis. As far as the allogeneic stem cell transplant, we have limited those to patients who are young with very high-risk disease. So if you have a 40-year-old gentleman who relapses, let's say, within 18 months of their auto transplant, we know those patients are not going to do well, irrespective of their cytogenetic characteristics. So those patients we would consider at least have the discussion about an allogeneic stem cell transplant. Obviously, that will change once we have more of the immunotherapies available.
Thank you for this answer. But still, I'm thinking about the allogeneic stem cell transplantation in multiple myeloma, especially nowadays with CAR T therapy. It has been mentioned actually in European bone marrow transplantation that we should avoid allogeneic stem cell transplantation as long as we are going to prepare our patient for CAR T cell therapy. What's your impression?
Yeah, that's we don't really, so there are two things we don't know about CAR T, right? One is the durability of response, because most of the trials right now, the best PFS we have seen, like for example, the BB2121 has been a little less than a year. Now, one could argue that is because those patients actually got the CAR T very late. But we also, so that's one thing. And the second is a lot of patients don't have access to CAR T yet. And only within clinical trials, and sometimes you have to wait for months to get on something. So, and again, in a young patient who's 40, let's say, we want to control the disease for the next 20 years, at least we should have that discussion if they have high-risk disease. If they have standard risk disease, and if they have had a good long remission from the first order transplant, we wouldn't consider allogeneic in those patients.
Thank you. The first question actually from the audience, Professor Kumar, can you illustrate more on lenalidomide refractory patients? This is from Dr. Mahmoud Al-Khalaf.
Absolutely. So the lenalidomide refractory patients are probably the most common patients we see at the time of the first relapse, because most of these patients are on maintenance. And increasingly, we are using maintenance long-term for these patients. So all those phase 3 trials that have been done using lenalidomide as a backbone doesn't really help us for these patients. And these patients should either be getting a monoclonal antibody with a proteasome inhibitor combination. So we have data with daratumumab bortezomib dex or daratumumab carfilzomib dex. And we also have data with isatuximab carfilzomib dex. The other option would be to use a proteasome inhibitor or an immunomodulatory proteasome inhibitor or a monoclonal antibody with one of the next generation immunomodulatory drugs like pomalidomide. So pomalidomide with bortezomib or carfilzomib or ixazomib, or we can use pomalidomide with daratumumab or isatuximab. So it's essentially using preferably a PI plus a monoclonal antibody. If you can't use that combination, PI or a monoclonal antibody in combination with pomalidomide would be the choice for these patients.
Thank you for the answer. My question to
yes, if I may,
Dr. Moussab now. Dr. Moussab, please, about the BV. If we used it for the patient with relapsed refractory Hodgkin's lymphoma, and later on he will go for allogeneic stem cell transplantation, do we expect that he is going to have improved, more severe or milder acute graft versus host disease, because we know that BV is an anti-CD30?
Yes, that's an interesting question. Thank you, Dr. Fahad. There was actually an early examination of this, because, as you know, CD30 targets activated lymphocytes, which are partly to blame for the GVHD phenomenon. And that study was actually not a positive one. So it looked like Brentuximab is not helpful for GVHD therapy. I don't think Brentuximab treatment per se alters the risk of GVHD post-allogeneic transplant, although that's merely speculative. That was not examined in that regard. However, as far as treatment goes, BV does not have a clear role. Nonetheless, checkpoint inhibition looks like they do increase that risk, particularly if the time or the interval between the last dose and allogeneic transplant is short, whether that's pre-transplant or post-transplant.
Thank you for this answer. Yes, please, Dr. Ahmed.
Yeah, if I may, well, great talks from both speakers, and well timed, I guess, again for both. Dr. Moussab, regarding, what do you think of combining? You already alluded to the combination of Brentuximab and nivolumab as a salvage. How do you see this evolving as a first salvage, avoiding chemotherapy? What's your thought about this?
Yeah, so that's a very good question, Dr. Ahmed. Now, again, this is still within the realm of off-label use. And it's not, BV is not approved for the treatment of any of those combinations. So obviously it's used with, as we use any off-label indication. But when I at least when we look at the phase 2 data, it did not look particularly better than combinational chemotherapy. I think using the combinational chemotherapy offers you the possibility to collect stem cells at the same time. And then you still save an additional line of therapy later on. Because these high-risk patients, the majority of them are cured, but you still have some of them that relapse, and they may use checkpoint inhibition. So I think if you exhaust your Brentuximab line of therapy, as well as checkpoint inhibition, whether that's pembrolizumab or nivolumab, I think you may be in a problem later on if the patient relapses. Now, that being said, there are additional treatment options that are being considered for Hodgkin's, and CAR-T is one of them, although that remains preliminary. But I think the main backbones of treatment that we have, or the classes of medications, are as you know, BV as well as checkpoint inhibition. And for myself, I prefer to save the checkpoint inhibitor to a later time point. Hopefully they will not need it, but they may need to have such treatment.
Okay, thank you, Dr. Moussab. There is another question here for Professor Kumar. Do you see any role for allogeneic stem cell transplantation in relapsed refractory multiple myeloma? This is from Dr. Khadija Ahmed.
Yeah, no, I think as we discussed before, I think definitely there is a limited role, I think, for allogeneic stem cell transplant. Most of the, I think the people whom we consider taking them to an allogeneic transplant in the relapse setting are the younger patients with high-risk cytogenetic features, or the younger patients who actually relapse very early after that initial transplantation. I think for those patients, it's certainly a good discussion to have with the patient, pros and cons.
Thank you, Professor. I think once we are waiting for more questions, I do have one question here. In fact, nowadays we can see some of patients with multiple myeloma, they do have some cure, even though very low percentage. When do you expect that multiple myeloma going to be a curable disease? Is it in our generation or the next generation?
That's a good question. I'm betting that it's going to be in our generation, especially with all the new therapies that have come along. I think the immunotherapies especially appears to be quite effective in getting rid of the disease and getting deep response. The key thing is figuring out how can we maintain that response. And I think using the different immunotherapies in combinations, maybe a CAR-T to get the disease under control, and maybe some T-cell engagers on a regular basis to kind of control the disease longer term, or immunomodulatory drugs, new cell modes, any of them to control the disease long term, might be able to eventually get us to that point.
Okay.
Dr. Fahad?
Yes, please.
Yeah, I have a question as well, and probably it's a
please.
continuation of this discussion to Dr. Kumar. Now, for relapsed patients post-auto transplant, we always, it could be, depending on the duration after transplant. However, I mean, this question of whether you would do a second auto transplant versus you would just continue, utilizing whatever unutilized of the novel therapies. I mean, how do you, what factors do you consider? I know you alluded into this briefly in your discussion, in your talk, but, for somebody who doesn't have, let's say, most of the time we do save some stem cells from the first auto collection. Sometimes we didn't have enough cells, and then exposing the patient to the second experience of going through this is a big hassle, and sometimes patients become reluctant and would prefer probably the novel therapies. And I don't see that. I mean, how do you see the results? I mean, is it compelling to go for a second transplant? How do you see this?
Yeah, so I think we have only a couple of trials that have actually directly asked that question of second order transplant versus traditional chemotherapy. We don't have any trials that have looked at the new combinations and compared them to doing a second order transplant. I think we also collect stem cells for a second transplant, but what is increasingly happening is that patients, as we just mentioned, don't often want to jump into a second transplant right away. They would rather try some of these newer therapies because we have so many different choices right now. But what happens over years is that as they go through multiple different regimens, their bone marrow becomes relatively beaten up and their blood counts drop, and then they can't go on a clinical trial or even get standard of care drugs. And increasingly, what we end up doing now is doing a second transplant to kind of reconstitute their bone marrow. So by using that salvage second transplant, we can get the myeloma under control, but we can also get kind of rejuvenate their bone marrow, and the counts are better now. And now they become eligible for clinical trials or other standard of care therapies.
Thank you. There is another question, Professor Kumar, from Dr. Hussein Badin. How you manage myeloma relapsing with brain lesions post BMT?
Yeah, that is a really challenging group of patients to treat. Because, thankfully, we don't see it very commonly, but CNS myeloma is something that, when you see it, you typically tend to see it in the post-transplant setting. There is no, for a well-proven strategy. Most of us tend to use intrathecal therapy to try and clear the CSF from the myeloma cells, but at the same time give systemic therapy. Now, there are some agents which we think maybe get into the CSF a little better. We tend to use more of the pomalidomide combinations with the PI. We don't have a lot of data with the monoclonal antibodies, but I think it's reasonable to assume that they would also help. Now, there are some experimental agents that have been tried. For example, Marizomib is a IV proteasome inhibitor that has got an excellent CNS penetration. There are clinical trials looking at that. Recently approved drug selinexor that has got a very good CNS penetration. In fact, it's being studied for GBM. So I think some of these newer drugs that have come through, we hope can provide the degree of CNS penetration that would be useful.
However, fortunately, actually, central nervous system myeloma is very rare. And this is good because I believe that the prognosis is very, very poor when the patient has central nervous system involvement with myeloma.
Absolutely. Yeah.
I'm thinking about the duration for the second transplantation. If there will be no questions, yes. In the past, we were saying that 18 months after the first transplantation, if there is relapse, we can go ahead for second transplantation. When lenalidomide maintenance becomes standard, we change that 18 months to 36 months. I'm feeling that 36 months is too long, really. Why we should not make it 24 months? What do you think?
Yeah, no, I think, there's no right or wrong answer. I think it all depends on the context that you are in. I mean, if they have other drug combination choices, then many patients may elect to go and try that instead of going to a transplant again so soon. The 36 is roughly, we are looking at the median PFS for a maintained patient is roughly about 50 months, 48 to 50 months. So we are thinking, we should at least have a 3/4 of that to say it is a worthwhile procedure to go through. But it's a very arbitrary number. I think people use anywhere from 24 to 36.
Thank you very much for this answer, Professor Kumar. Thank you, Dr. Moussab. It was really an excellent talks, and we enjoyed it very much. At the end, I would like to thank Takeda for their participation in our webinar. And have a nice evening, and see you, inshallah, next week with the next webinar. And it is going to be about, I think, how I treat low intermediate risk MDS. And the second talk going to be about real world experience in relapsed refractory multiple myeloma. Please don't miss these sessions because it's going to be very fruitful and very nice. And at the end, really, I would like to thank everybody of you for attendance our webinar tonight, as well as to thank very much our speakers. And have a nice evening, and see you later. Thank you.
Thank you.
Thank you all.
Thank you. Thank you.
Have a good evening.